So back to SVTs, we already discussed focal atrial tachycardia. Now we'll move on to junctional rhythms. So the AV junction can become the dominant pacemaker in a few different scenarios. The most common is an escape rhythm, when there is no impulse coming from upstream in the atria, or when it's very slow. The AV node can take over as it has these intrinsic properties of automaticity. The intrinsic rate that it normally will fire at will be between 40 and 60 beats per minute. The most frequent time you'll see this is just for a single beat, but in some cases the AV node may take over as it's firing faster than the SA node. In other cases, rather than taking over because the sinoatrial node is too slow, it might actually be sped up itself by increased automaticity. And the rhythm in this case would either be called an accelerated AV junctional rhythm if it's between 60 and 100, or an automatic junctional tachycardia if it's above 100 beats per minute. Both of these rhythms are associated with structural heart disease, and a classic example would be following an MI or following cardiac surgery. When we have a junctional rhythm, the activation of the atria is in the reverse direction, and will therefore see negative P waves in the inferior leads, and usually they'll be upright in AVR and lead 1. So the P waves may come immediately before the QRS, alternatively at the same time as the QRS, so superimposed within the complex, or they may come directly after the QRS complex in the ST segment. It's often said that this reflects where the abnormal focus that's firing is within the AV node, but in reality you can't say this for certain because it depends not only on location but also on the speed of conduction. So the most common type of SVT, if you exclude AF and flutter, is AVNRT. And in a subset of patients, instead of a single pathway within the AV node, there are two pathways. A fast pathway and a slow pathway. Importantly, the fast pathway has a long refractory period where it can't be reactivated, and the slow pathway has a relatively rapid refractory period, meaning that it's free to be activated pretty quickly after it's done depolarizing. An episode of AVNRT is triggered when you have a premature atrial complex, and that travels towards the AV node. The fast pathway is still recovering in its refractory period from the previous beat, but the slow pathway is ready and it will carry the impulse from the premature atrial complex. By the time the impulse travels down the slow pathway, the fast pathway is now out of its refractory period, so the impulse will travel not only forward towards the ventricles but also in a retrograde fashion via the fast pathway. The outcome is a re-entry circuit. So when we're looking to identify AVNRT on the rhythm strip, we'll have a regular tachycardia with a sudden onset and a sudden termination initiated by a premature atrial complex. The heart rate will range between 140 and 220 beats per minute. And the P wave, like for a junctional rhythm, will be inverted in the inferior leads, meaning retrograde atrial activation. And it may come immediately before, during, or after the QRS complex. Most commonly, they're actually within the QRS complex, but on the odd occasion, they may coincide with the terminal portion, so the S wave, and it produces a pseudo S wave like you can see there. The final SVT we're going to talk about is AVRT, so atrioventricular reentrant tachycardia. And this type of tachycardia requires a bypass tract or an accessory pathway that can conduct an impulse from the atria to the ventricles. Approximately 1 in 1,000 people will have an accessory pathway, and it's more common in children and adolescents. So the accessory pathway in the case of Wolff-Parkinson-White syndrome may be visible on the ECG, but it may also be concealed. So if present, the impulse from the atria will prematurely activate the ventricles, and from there onwards conduct via cell-to-cell conduction. The early activation of the ventricles will show a short PR interval and also a widening or a slurring of the QRS complex. This is called a delta wave. The ST segment and the T wave are typically deflected in the opposite direction to the delta wave. With an accessory pathway, you can actually see variant different tachycardias. The most common would be orthodromic AVRT. The impulse travels down the AV node to depolarize the ventricles, but then it travels back up the accessory pathway to the atria and causes a loop. It's often initiated by a lone premature atrial complex, as was the case with AVNRT. So this complex blocks the accessory pathway, which is later activated in a retrograde fashion. In the orthodromic version of AVRT, the heart rate is typically between 140 and 250 beats per minute. The ventricles are activated by the rapid His-Purkinje system, so it's actually a narrow complex tachycardia. The antihydromic version is a wide complex tachycardia. But going back to the orthodromic version that we spoke about before, since the atria are activated sequentially after the ventricles and the accessory pathway is a fast pathway, the P wave will come very soon after the QRS complex. And that's what happens. You find it in the ST segment, usually. And the P wave will be negative in lead 1. This is a good method of differentiating between AVRT and AVNRT. Where, as we said before, usually the P wave would be within the QRS complex or in the terminal portion of the QRS complex.